Good evening. So we now come to the third and final motion. There is still benefit in using protons in prostate cancer. Proton therapy was first used in prostate cancer more than 4 decades ago, but till now it remains a subject of some controversy amongst physicians, patients, and payers alike. And once the proton centers open here in the near future, the question of the benefit of using protons over other well-established radiotherapy modalities will become very real to us indeed. So thankfully, we have two world-renowned experts in prostate radiotherapy, Dr. Jason F. Statayu and Professor Peter Hoskin, to go hammer and tongs debating this motion. There's nothing like a good debate to focus our minds and clarify the issues. So for the proposition is Dr. Jason F. Statayu, who is Professor of Radiation Oncology at Harvard Medical School and Director of the GU Division in the Department of Radiation Oncology at Mass Gen Hospital. He's an internationally recognized leader in the field of GU malignancies and principal investigator of various multi-center trials in bladder and prostate cancer, including proton therapy. So let's begin the debate.
Thank you so much for allowing me to join your wonderful symposium. I will be talking in favor of the proposition there's still benefit in using protons for prostate cancer. So let's debate. Indeed, IMRT has completely replaced 3D conformal radiation, certainly in a short period in the United States. And that, by the way, all happened without a randomized controlled trial. And now we have proton therapy. And protons, well, they're in the crosshairs of controversy, with many claiming cost as the main limiting factor. Cost more, but is it worth more? Well, let's just look at what patients have to say. There is strong patient preference for proton therapy. In fact, it is the only cancer treatment with a fan club. And yes, books about protons for prostate cancer have been in the top 5 bestsellers on Amazon for over a decade. And patients are crisscrossing the United States in search of proton therapy. Some say we're living in a state of gizmo idolatry. Well, if we look at Gartner's hype cycle, when a new technique is introduced and a celebrity is treated, it goes through the peaks and troughs of being the best thing since sliced bread. I wouldn't give it to a dog, and eventually figuring out appropriate use. I would argue we have now reached that appropriate use sort of balance with protons for prostate cancer, and there is a role for protons in prostate cancer treatment. So let's look a little at the history, physics, and clinical potential here initially. First of all, it was in 1974 when the first prostate patient was treated with protons. And the FDA approved protons in 1988. So it is very important to know that this is not an investigational treatment. It's not new. IMRT is much, much newer and doesn't have as many decades of experience as does proton therapy. What about the physics? Well, that's clear. Look at these pristine Bragg peaks of selected energies that go to a certain depth and stop. Indeed, protons are particles that have charge and mass and therefore defined range in tissue. They contrast to photons, which continue to deposit dose beyond the target in tissue. So again, with protons, it covers the tumor with less entrance, less exit dose. And these principles are critical because radiation-related complications do not occur in unirradiated tissue. Normal tissue irradiation does not benefit the patient. One can optimize the therapeutic ratio by maximizing radiation dose to the tumor and minimizing normal tissue dose. Indeed, protons have gotten even better with spot scanning beams, scanning technology, or what's called intensity modulated proton therapy. So this dose deposition is even better defined. And what's the clinical potential of all of this? Well, lower integral dose and absence of exit dose leads to less toxicity and improved treatment tolerance and reduced late effects. If ever a picture was worth 1,000 words, here is a patient being treated with medulloblastoma. Look at protons avoiding all those anterior organs. Yes, there are accepted adult indications for skull-based tumors, eye tumors, spine and sacral tumors, and many other opportunities, including prostate cancer. It's an opportunity. So, do the physical advantages translate into measurable clinical benefit for common cancers such as prostate cancer? Well, that's the million-dollar question. And there is certainly data to suggest that the answer may be yes. And even more rigorous data is coming. So let's look at the data. Well, here are some plans. Which plan would you rather have? Look at this, all this extra dose with IMRT when treating the prostate and the pelvis compared to these beautiful proton plans. Indeed, if you minus the two plans out from one another, this is what you get. The target is treated to the same dose. So cure rate should be the same, but you have all this extra dose bath in the pelvis with photons compared to protons. In fact, that leads to liters of body excess volume tissue that is irradiated with IMRT compared to protons. If you look at DVHs, the green and the blue lines are proton plans, 3D conformal and IMPT protons compared to the red IMRT. Look at all this rectal dose sparing, especially in the low to moderate dose range with protons. In fact, IMPT allows partial prostate boosting and really, exciting future possibilities. Anterior beam fields with protons allows avoiding the hip joints and more of the rectum, especially if we use a hydrogel spacer. So lots of exciting future possibilities. So let's look at scatter dose. The further you get away from the target, there is far less scatter with protons compared to photons. And this leads to less risk of radiation-associated second cancers, both in field and out of field. There's about a 1/3 reduction in second cancer risk with protons. And that's been proven in clinical cohorts such as this one from MGH. Now let's look at my opponent, Peter Hoskin. He is a co-author on this paper. Even he said, proton planning studies suggest very low second cancer risks. Until there is sufficient clinical evidence regarding second cancer risks associated with modern irradiation techniques, the data produced from planning studies is relevant when considering which patients to irradiate and which technique to employ. And in fact, there is clinical evidence now too. So he's totally in my camp as well. When we look at clinical data, such as patient-reported outcomes in some clinical cohorts, there's less GI acute toxicity with protons. There is also less GU toxicity in some population-based studies. In fact, other population-based studies suggest both less acute and late GU and sexual toxicity. We are generating the rigorous data, however. Yes, and it's happening in prostate cancer. And you can't run a randomized phase 3 trial of protons versus photons if there isn't at least equipoise. And yes, the particle trial is that randomized phase 3 trial of 450 men, protons versus IMRT, with quality of life outcome, primary outcomes. And this trial, very exciting to announce that in November 2021, fully accrued 450 participants. There's also a companion registry for over 760 patients on study. So the definitive answer is coming. And this is how many of us feel as we await those results. So in conclusion, proton therapy is safe, effective treatment. It's not investigational, and it has some physical dosimetric advantages over IMRT. It can spare normal tissues and avoid the lower dose radiation path. It can decrease integral dose, which can lead to lower rates of second cancers, especially in younger men. Proton therapy outcomes are at least as effective as alternative radiation modalities as per those retrospective studies, but the rigorous randomized controlled data is coming soon, and clinical trials must be supported to fully realize the potential of proton therapy. The cost of building proton therapies is decreasing. We need to promote scientific innovation and creativity while looking to decrease cost and maximize efficiency further. We need proton therapy, ideally geographically well distributed for access, with an emphasis on evidence development and decreasing access disparities. So let me leave you with this thought. Never trust atoms. They make up everything. And to my opponent, well, he is wrong, but I am actually Canadian, and I agree with everything he's saying as well. Thank you for your attention. Thank you.
Right. That was an energetic exposition on the potential benefit of protons in prostate cancer, which may have persuaded a number of us. But let's hear from the other side first, before coming to any premature conclusions. Professor Peter Hoskin is no stranger to many of us. He's now Professor of Clinical Oncology in the University of Manchester and Honorary Consultant in Clinical Oncology at the Christie Hospital, Manchester, as well as University College Hospital, London. In Manchester, he leads the radiotherapy-related research group and is currently the clinical editor for the Green Journal. He will now present the opposition's case.
Thank you for inviting me to take part in this debate at your annual dinner. I'm really sorry I can't be there to share the dinner with you. And the title is, There is Still Benefit in Using Protons in Prostate Cancer. But of course, that's the title. I'm against the title. There isn't. So what is the case? Well, I've nothing against protons. I work part of the time in Manchester, and just down the road, there's this blue plaque, and that is for Ernest Rutherford, who discovered protons in the laboratory you see on the left. That's a current photograph in the Rutherford laboratory using the equipment on the right, which, as you'll see, is somewhat rudimentary, but nonetheless enabled him to identify atomic particles. And indeed, in Manchester, we have the UK's only active proton center at the moment, opened 3 years ago, the Christie Proton Center. So I have nothing against protons. They are useful in their place, but their place is not prostate cancer. So what has happened over the last 100 years or more since they were discovered? Well, for protons, there's 90 proton centers worldwide. That certainly wouldn't be enough to treat all the prostate cancer in the world. 37 of them are in the US. And they're used for highly selected, mainly pediatric indications. But there's no level 1 evidence for any of that activity. And there's no mention in prostate standard of care guidelines of protons as standard of care. Contrast that with photons of whatever type you like, whether it's modern IMRT VMAT, whether it's brachytherapy, whether it's SBRT. They are available in virtually every cancer center worldwide, and they are the standard of care for prostate cancer. And why is that? Because there is extensive level 1 evidence to support their use. But they both started out together. They both started out round about the beginning of the 20th century. So is there something wrong with protons? Well, it took them 50 years to be used clinically, and that was in neurosurgery and treatment of pituitary tumors. And even then, the efficacy is not well documented. First treatment center at Loma Lindy was opened in 1990, and that was the first high-energy proton facility available to treat deeper tumors. And currently, it has minor applications in pediatric and CNS tumors and choroidal melanomas. In contrast, photons, early use, shortly after the discovery of them, standardized methodology for delivery within 10 or 20 years, early major impacts in common tumors, seeing regression of cancers in the skin, in the breast, and the cervix was really dramatic. And as time evolved, they became more technologically adept at recognizing and addressing complex volumes, organ motion, all the other problems we're familiar with and which we can now largely solve with the modern ways of delivering radiotherapy with VMAT, IGRT, IGBT, SBRT. I don't need to extend that for this audience, but none of that is available with protons. But the most compelling issue is the evidence base. For photons, we have an extensive evidence base with level 1 evidence, endless randomized controlled trials. For protons, it's negligible. In fact, there's very little at all. Let's look at it. This is a nice review produced by the Boston group. You see there at the top, the standard way of depicting a potential advantage for protons. On the left, the dose distribution from a proton beam. On the right, the fixed field IMRT distribution showing a large low dose bath despite targeting the prostate in the center. But of course, that is not state-of-the-art photon delivery. We can do much better. Here we see on the left SBRT, a very much more conformal dose delivery than you get with protons and without the high dose going through the hips. On the right, brachytherapy. Brachytherapy, the most conformal way of delivering high dose radiation. And you see there little or no dose outside the prostate gland. And then look at the data on there. Most of it is database data or non-randomized comparative data, because that's all there is. So this is low quality data. And this is as published in 2019, not much has happened since then. And the story that protons may be less toxic, look, higher acute GI toxicity in one of those studies, higher late GI toxicity in 3 of them, and equivocal findings in another one. This is not compelling evidence to switch to protons. And the other thing is the business case. In the UK, the Proton Centre business case built a proton centre for £150 million. It cost 25.5 million to run it per year, and that's to treat 750 patients per year, of which 50% are thought to be research patients. Let's compare that with a modern linear accelerator. It costs about 2 million. So you can work out, you can get over 70 of them for the price of a proton center. But if you add in an afterload, well, that's only 0.25 million pounds. And each working to capacity will probably manage to treat about 4,000 patients per year. That is the cost of nearly 5 proton centers. So you can see that the sums just don't stack up. And there's a very nice study here from the US, looking at the comparative cost effectiveness of laparoscopic prostatectomy, intensity modulated radiotherapy, and proton beam therapy. And the bottom line is protons are much more expensive. Here you see the Medicare reimbursement costs 32,000 against 18,000. You see in a Markov model looking at the societal costs, including impact on the patient's lifestyle and employment and so on. Protons turn out to be about 3 times as expensive as photons, and the cost per QALY is 26,766. This data, of course, is not robust. And why is it not robust? Because, as you see on the bottom line there, the evidence to put into the model is very limited, particularly in terms of cancer control and quality of life. But that's what we need to know to decide whether to use protons or not. So the debate is, there is still benefit in using protons in prostate cancer. Well, I think I've shown you there is no benefit at all. There never was a benefit. There is still no benefit. Despite over 100 years of trying, protons still have to find a place in prostate cancer, and there is still no robust evidence. So my view is that protons for prostate cancer, at least, are destined for the scrap heap. They're in good company, as you see at the bottom there. Concorde was a wonderful aeroplane, but not cost effective. Some of the others were perhaps not such good inventions. But in that line, I think we will soon be adding protons for prostate cancer. And there I will close my argument.
Professor Hoskin has authoritatively argued the current lack of high-level evidence for protons in prostate. And now Dr. F. Satayu has the first right of reply. So let's listen.
I appreciate all the good points my esteemed colleague, Professor Hoskin, has made, but he is misguided. This debate is not whether protons are superior, it's whether there's still benefit in using protons for prostate cancer. And as I have to bring this up again, as he wrote, protons and brachy planning studies suggest very low second cancer risks. And until there's more data, the data produced from planning studies is relevant. He's right. And by the way, not all patients are candidates for brachytherapy, as everyone well knows, so protons have a role. And yes, unlike what he said, there is actual data about second malignancy risk. This is a matched cohort study with 1,450 proton patients, median age 56. Look at that hazard ratio in favor of protons in terms of avoiding second cancers. And this age range is relevant to the prostate cancer population. He loves to show my paper, and I appreciate that. Thank you, Professor Hoskin, because if you actually looked at the table carefully and he added up all the arrows going down, suggesting benefit to protons, it's 5 against 4 compared to photons. Protons win. At least there's equipoise, and there could be potential benefits, so there may still be benefit. Cost, yes, of course he's going to talk about cost, but once you add IGRT, cone beam, CT, brachytherapy to photons, the relative cost of protons is not that big a deal, and certainly a spit in the bucket compared to current systemic therapy options. And as we all know, as technology matures, cost goes down. Look at what's happened to computers and to cell phones. And this is what's happened to protons over the years. Do you think so many proton centers would be popping up around the world if it were a bad business model? And yes, of course, he brings up Concorde and parallels it to proton therapy, saying they're in the scrap heap. Clearly, Professor Hoskins is not reading the news. United Airlines has revived Concorde. It's traveling twice as fast as modern airliners. Similar to proton therapy, Concorde has figured out how to be cost effective. So in rebuttal, protons are not experimental. There is long-term clinical data on cancer control and quality of life. It has exquisite dose symmetry. The decreased integral dose second cancer risk is real and relevant, especially in younger men. Clinical trials have been done and will fully realize the potential of protons, and there's many exciting new developments, pencil beam scanning, image guidance, even stereotactic body proton therapy, which will always be better than SBRT with photons. The cost of building proton centers is decreasing, the efficiency is increasing, and reference pricing is an option. So you must agree with the motion that there is still benefit, some benefit, in using protons for prostate cancer. Thank you.
Looks like things are heating up with Dr. F. Satayu's high-octane rebuttal. Professor Hoskin will now say his piece.
Thank you. It's a great pleasure and privilege to be debating with Professor Eustathiou, whose identity I did not know when I prepared my earlier talk, and indeed quoted one of his papers showing a characteristically eloquent description of the higher toxicities reported with protons. His arguments, of course, rehearse those which are incontrovertible and relate to the physics of proton beam distribution compared to a single photon beam distribution. Carefully, however, he avoids comparing Highly conformal photon distributions, such as VMAT or SBRT, and inevitably, since it represents the most focused conformal dose delivery possible, no mention at all of comparison with brachytherapy, the ultimate conformal photon delivery. And for obvious reasons, in that there are clearly vastly superior distributions to protons obtained with SBRT and brachytherapy, as I showed in my previous talk. Furthermore, this is highly relevant to prostate cancer, unlike medulloblastoma, which I believe was his illustration. He graciously admits that there is no prospective level 1 evidence for protons, unlike photons, but promises more rigorous data in the future, which is good news. But then I gather that's from a single trial of less than 500 randomized patients. Compare this with the photon fractionation studies of recent years, where we had many thousands, if not 10,000s of patients, all randomized, all rigorously treated and followed up, and then contemplate the statistical power with which one might generate the role of protons in prostate cancer. Now, the only clinical data he did mention was that for second malignancies, and I'm gratified to think he's read in detail one of our papers. This was, of course, based on clinical data. But clinical data in relation to photon treatment, not proton treatment. And that treatment was delivered some time ago using outmoded techniques. There is, for obvious reasons, no robust data on second malignancies after protons. Understandably, he claims they will be less. But note, there is an entry beam and there is an exit dose with protons. And modeling studies suggest it will not be zero. Indeed, only one modality has been shown to have no excess second malignancy incidence when treating prostate cancer, and that uses photons. And that, of course, is brachytherapy. And so, the case for proton therapy to be superior to photon therapy in prostate cancer has a long way to go yet to be proven.
Wow, with those stunning reports from both sides, will the motion stand or fall? There is now an opportunity for you, the floor, to put in your quick-fire questions regarding the motion in the chat box, which I will then read out. Dr. Estatiu is present live, but unfortunately, as Professor Hoskin is not available, he's kindly agreed to answer questions on both sides of the debate. But before that, since he's here, I'll first give him an opportunity to have the last word over Professor Hoskin and give him a couple of minutes to respond to the rebuttal. So while he's doing that, please enter your questions. So Dr. Estatiu, please.
Sure, it's a pleasure to be here and fun to debate Professor Hoskin. Sorry that he couldn't be here as well. I mean, I think it's very clear that I won the debate. I have to make two disclaimers though. Number one, I treat patients with both protons and photons. And number two, I'm the principal investigator of the particle randomized trial of protons versus photons. So I truly do have equipoise to this question. And I think there are strong arguments on both sides of the coin. There was something in the chat about the results of the particle trial coming in 5 years. That's actually not true. The particle trial fully accrued in November of this year, and results will be available in 2 years. It is a 2-year primary endpoint, and it's a patient-reported quality of life trial. And you're going to see lots of robust evidence. I also saw in the chat there questions about the rectal spacer. Absolutely, the rectal spacer is fantastic, and there's trials showing less rectal toxicity. And so what's the added value of protons? Well, we'll see, because the particle trial actually stratified patients by use of rectal spacer or not, and it stratified patients by use of moderate hypofractionation versus conventional fractionation. We're going to get all those answers from that trial. But I would just say that the potential benefits of protons don't just lie in rectal toxicity, right? And I think if you really think about it, is there still benefit? It doesn't define how much benefit, but in certain situations, young patients, where you do want to decrease the very rare possibility of second cancers, I think the data is pretty clear that protons offer that potential. And although that's very hard to prove because you have to follow tens of thousands of patients for decades, If you just think about that one point, you would probably convince yourself that there is still potential benefit to proton therapy. And I think I also highlighted in the talk all the new advances, anterior beams, pencil beam scanning, IMPT, all of that. In some ways, protons has been lagging behind photons, right? The introduction of in-room cone beam CT, the introduction of pencil beam scanning has always been a little behind photons, but I think once protons catch up, again, there is exquisite dosimetry, and I think there's the hope for possible benefit. The last thing I'll say is cost. Yeah, of course, cost is always brought up, but Professor Hoskin was misguided in the way he showed that. I mean, he said 150 million pounds for every. That's for a multi-room, multi-gantry facility, and he compared it to a $2 million, Linac. That's not a fair comparison. Number one. Number two, I don't know where he's getting those cheap Linacs. Good Linacs these days are at least 4 to 5 million. But the point is, nowadays you can get single room proton centers for 25 to 30 million, right? And pricing is totally artificial, certainly in the US. And I think you're seeing a trend towards what's called reference pricing, meaning if there's a diagnosis of prostate cancer, you can treat with protons or photons, you'll get paid the same, okay? And then allow centers to make the decision whether or not they want to invest in such centers. I think proton therapy is a great opportunity for generation of philanthropy into oncology, to help build those centers and then introduce proton therapy into practice. And with that, I'll leave it to the discussion and questions.
Thank you, Dr. Esathiou. There's a question from Jeffrey asking about what about locally advanced prostate cancer requiring pelvic lymph node radiotherapy and boosting? He proposed the interesting idea of proton to the pelvis, but with brachy and SPRT boosts. I wonder what your opinion is on that. Would that be something that is attractive?
Yeah, I think most of the data in prostate cancers in treating an intact prostate only basically fields, but there's lots of interesting planning, and I showed a picture of it in the talk of treating the pelvis as well. And you see the avoidance of this whole low to moderate dose bath with protons. So I think there is a role for treating the pelvis with protons. I think absolutely for local therapy, you could combine it with brachytherapy, and the dosimetry of brachytherapy is certainly exquisite. Not all patients are candidates for brachytherapy. We all know that, right? So certainly there's still roles for using proton therapy to treat the prostate. But I think that you raise, there's also work looking at using protons in the post-op setting, right? And there's some studies that have, started to look at that. Do remember, when you demand level 1 evidence, randomized controlled data, you need to have had a critical mass of proton centers available internationally, nationally, to generate that kind of trial, right? So 15 years ago, you couldn't run these trials. So we have been doing that now. It's been happening in a lot of different disease sites with proton therapy, but it sort of couldn't happen until now, until there was that critical mass of proton centers to be able to properly accrue to well-designed trials. So don't be swayed by, oh, there's no level 1 evidence. Of course there's no level 1 evidence. There wasn't the ability to generate that, but now the trials have been done.
Okay, I think we'll just have one last question from Daniel. He asked, in your opinion, what level of proton technology is minimal for prostate in this current era? For example, is the minimum, proton pencil beam scanning? What level of onboard imaging do we need? So what are your thoughts on that?
Yeah, I think that it's a great question. I mean, it depends on how proton centers are being set up. If you're developing a national proton center, or there's clear regional kind of government-based, funded centers, versus are you building in private centers a single treatment unit? Okay, so I think it does, what model is being followed to build matters. But these days, if I were, for example, a single center that wanted to bring in protons, I would probably invest in a single room center, and I would pack it with modern technology. Absolutely pencil beam scanning, and absolutely in-room imaging, in-room CT, cone beam CT capability. There's no doubt about that. The smaller the spot size, the better the plan. And one of the big ways that protons have always lagged behind photons is the lack of as good image guidance. Nowadays, that is available with in-room CT for protons.
Okay, thank you so much for your wise words, Dr. F. So let's now poll the floor to see what everyone thinks about the motion. So again, there are three options for the proposition, for the opposition, and finally neutral or fair-minded. So lock in your votes now. Wow. So almost 70% for the proposition. So I think we're going to see quite a few patients going on the Proton machines when the Proton machines come online in Singapore. So with that conclusion, I draw a close to this debate. I would like to thank Dr. F. and Professor Hoskin for that very spirited last debate. I hope it was as enlightening for you as it was for me. The grand proton therapy debate is now over, and I'll now hand over the time to the MC for the night.